Okay, and moving on with our pathophysiology of rheumatoid arthritis. Um, Several types of leukocytes are attracted out of the circulation. The phagocytes of inflammation, which we've talked about over and over in different inflammatory problems. Neutrophils, macrophages ingest the immune complexes and release powerful enzymes that degrade the synovial tissue and articular cartilage. Inflammatory and immune processes have several damaging effects on the synovial membrane. Swelling from the leukocyte infiltration, hyperplasia of the synovial membrane as the cells enlarge abnormally. Compromised circulation causes hypoxia and metabolic acidosis. Acidosis causes inflammation from the release of the hyperlytic enzymes, initiating erosion of the the articular cartilage, and inflammation in the supporting ligaments and tendons. Inflammation causes hemorrhage, coagulation, and fibrin deposits on the synovial membrane. Fibrin develops into granulation tissue, and we call this a pannus. And that goes back to here, the pannus formation. So we've got the articular cartilage, is where it's supposed to be, lining the bone and helping the joint move for movement with the synovial cavity, synovial membrane. And now we've got inflammation of the synovial membrane because of the disease of our rheumatoid arthritis. And with all of these inflammatory markers and fibrin formation, we've got the pannus formation and erosion of the cartilage to the point where the bones will be fused. Pannus formation does not lead to synovial or articular regeneration, which is what we would like it to do. But the pannus, no, it's part of the disease development due to this autoimmune disease. But it forms scar tissue that immobilizes the joint, and then you have bone on bone. So clinical manifestations of this very, very horrible autoimmune disease are inflammation, fever, fatigue, weakness, anorexia, weight loss, generalized aching and stiffness. So basically like they have the flu, not feeling well at all. Symptoms appear over a period of weeks or months. Very painful joints, tender and stiff. Pain early from the disease is from the swelling. Later in the disease, it's from the sclerosis of that subchondral bone and new bone formation, and where the joint just goes away. It's bone on bone. Joints most commonly involved are the hands, fingers, wrists, and later involvement of large weight-bearing joints. And that is why this disease is progressive. People may start with it in their hands, and then within 5 to 10 years, they may be in a wheelchair. It's very, very serious stuff. The difference between this one and OA, there's several differences, but one that I'll point out right here is rheumatoid arthritis. They have prolonged morning stiffness after they wake up, and it lasts more than 30 minutes. And osteoarthritis, they'll also have morning stiffness too from laying still all night, but it subsides within 30 minutes. So that's one of the distinguishing factors. Clinical manifestations. Joint swelling is widespread and symmetric. It's both sides of the body. It does not discriminate because it is autoimmune, and it's where osteo may just be one, it may just be your right hand, not the left hand. So it's widespread and symmetric. That's what that means, both sides. Caused by increasing amounts of inflammatory exudate in the synovial membrane, hyperplasia of the inflamed tissues, and formation of new bone. And mind you, formation of new bone, and you're thinking, well, that's good. No, it's bone where it's not supposed to be. And so that's not okay. On palpation, the swollen joint feels very warm, and the synovial membrane feels boggy, very soft. An inflamed joint may lose some of its mobility. Well, of course it's going to. It hurts. Evaluation and treatment of rheumatoid arthritis. Physical exam and x-rays, serology tests. And those are blood tests for that rheumatoid arthritis factor. It's called an RA factor. And circulating immune complexes. The American College of Rheumatology lists diagnostic criteria as Criteria 1 through 4 with joint signs and symptoms must be present for 6 weeks because maybe it's something else. That's a long time. Treatment can be surgical and non-surgical. Sometimes they go in and do joint replacements. Non-surgical, the rest of the inflamed joint and whole body rest for several hours daily, use of hot and cold packs, physical therapy, aggressive early intervention. They'll use DMARDs, which are disease-modifying anti-rheumatic drugs and biologic response modifiers, diet high in calories and vitamins, corticosteroids for inflammation, and anti-inflammatory drugs taken orally or injected into the joint, depending on what's giving them the problem. Symptoms of RA versus OA, again for rheumatoid, joint pain, step to swelling affecting multiple joints, symmetrical symptoms affecting both sides of the body, and morning stiffness lasting longer than 30 minutes. Additional symptoms will be like fatigue, fever, and malaise. Osteo is joint pain and stiffness, usually affecting hands, fingers, or knees. Joints on one side affected worse than the other, and sometimes not at all on the other side. Morning stiffness can last fewer than 30 minutes, and possible spine and hip pain as well. They are very different, and the patho of those two are different. Okay, so gout. Let's move on to gout, and this is our final disease entity in this module. 90% of patients with gout are men. Gout attacks can be triggered by stress, alcohol, dehydration, or injury to a joint. Kidney stones occur in 10 to 25 of patients with gout, and we'll talk about that in just a minute. Persons with gout are 1,000 times more apt to get kidney stones. So basically, what is gout? It's crystal deposits in connective tissues throughout the body. Uric acid crystals. Why is it there? When these crystals occur in the synovial fluid, the inflammation is known as a gouty arthritis because it's not just arthritis, we've got an inflamed joint, but we've got it because we've got uric acid crystals deposited in that joint. Gout is related to purine, which is an adenine or guanine metabolism. Affected patients can have accelerated purine synthesis, breakdown, or poor uric acid secretion in the kidneys. So basically it has to do with a purine breakdown, and instead of being excreted like it's supposed to be, it's a buildup in the blood. And we know a lot of blood flows to the kidneys, so it can block the kidneys to the point of really hurting them. It can be caused by an accelerated purine synthesis, a breakdown in that whole purine synthesis, or poor uric acid secretion in the kidneys. Mechanism for crystal deposition, like where it's deposited. Lower body temperatures, decreased albumin or glycosaminoglycan levels, changes in ion concentration and pH in trauma. Clinical stages of gout, they can be very asymptomatic with very high uric acid levels. Remember, the body compensates over and over and over. Acute gouty arthritis is extremely painful. And that's, again, there's that word acute. That means something's going on right now. Swelling and tenderness. Tophaceous gout is used synonymous with chronic. It can last for months, years, asymptomatic, and then they'll have exacerbations. Urate crystals can occur in cartilage, synovial membranes, tendons, and soft tissue. So again, it's another inflammatory condition of joints, but due to a different reason, is because they have too much uric acid. Goals are prevention of attacks and treatment when they occur. Treatment of choice during an attack would be NSAIDs. Indocin, naproxen work very, very well for gout. Glucocorticoid injections, potent anti-inflammatory, treat acute gout into a joint, and they may just inject it right into the joint. Prevention, we have some drugs that actually lower uric acid, but in different ways. Colchicine has been available since late 1930s. It's a uric acid inhibitor, so it inhibits the production of uric acid. Also prevents inflammation by preventing white blood counts from infiltrating an area. Most effective if it's taken 24 hours after the attack. Probenecid increases excretion of uric acid by blocking reabsorption in the kidney. And then allopurinol blocks the xanthine oxidase so that uric acid formation is slowed down. Another treatment for gout is dietary changes. We've got avoid high purine foods such as meats, and you can read the rest of it, but a lot of it is meat. And then also avoid moderate purine food. So the high purine has got meat, moderate has chicken. And it used to be seen or thought of as they called gout, like centuries ago, as a king's disease, because the kings were the ones that ate meat more than anybody else. And of course, it's more predominant in men, and most of the kings were men. So just to point it out, with these type of foods, if you are having any arthritic problems or gout, basically you need to look at a vegetarian diet. You will do much better. Higher level of dairy product intake decreases the risk. So then again, lots of yogurt, things like that. Okay, that ends our presentation for musculoskeletal. I just wanted to go over one acronym with you before I leave you, and I should have put it in a slide, but I didn't. And it's a treatment for musculoskeletal injuries, period. And the term is RICE. I don't know how you're going to remember RICE with muscles and bones, but a RICE stands for rest. R is rest. I is ice. C is compression. And sometimes that's not always going to work with a musculoskeletal injury, because if we're compressing a very swollen area, that's not going to feel too good. And then E is elevation. So if the fracture is a severe bone fracture that causes blood loss, treatment will also include direct pressure to control the bleeding, and I think that's what they mean by compression. And then fluid replacement as soon as possible to prevent or treat hypovolemic shock. So again, RICE can be an acronym for musculoskeletal injuries, which means rest, ice, compression, and elevation. Okay, well, I hope you learned something, and thank you for your time. Bring your questions with you to class. Bye-bye.